Welcome to this medicine masterclass on Parkinson's disease. Parkinsonism has a triad: tremor, rigidity and bradykinesia. The tremor tends to be worse at rest and is described as pill rolling due to the action of the thumb over the fingers. Rigidity is where the patient exhibits increased tone throughout the movement. The combination of rigidity and tremor give rise to cogwheel rigidity. Bradykinesia is a slowness of movement, particularly a slow initiation followed by progressive reduction in speed and amplitude of repetitive actions. There may be a paucity of movement, an expressionless face, decreased blinking, and a monotonous hyperphonic speech. Other features include micrographia. They may have a reduced arm swing when walking, exhibit small shuffling steps, freezing at obstacles, and they may have a flexed trunk which helps shift the center of gravity to facilitate movements. The pathology is due to degeneration of the dopaminergic neurons in the substantia nigra, pars compacta, associated with Lewy bodies that causes decreased striatal dopamine levels. And this is what gives rise to the various manifestations. The motor symptoms occur due to degeneration of the dopaminergic neurons in the substantia nigra. The cognitive defects arise due to the degeneration of the dopamine neurons in the mesocortical and mesolimbic pathways. The autonomic dysfunction occurs due to the depletion of dopamine in the hypothalamus. The freezing phenomena arises due to the degeneration of the adrenergic neurons in the locus coeruleus, and dementia can occur due to degeneration of the cholinergic nucleus. There are some Parkinson's plus syndromes to be aware of. Progressive supranuclear palsy, also known as Steele-Richardson-Olszewski syndrome. This is where you have Parkinsonism along with a vertical gaze palsy. Multiple system atrophy, also known as Scheidegger syndrome, is where you have Parkinson features along with autonomic features such as postural hypotension, bladder dysfunction, and cerebellar signs. Lewy body dementia is where you have Parkinsonism accompanied by florid hallucination, Lilliputianism, where patients classically report seeing little children or little people. Corticobasal degeneration is Parkinsonism along with cortical sensory loss, apraxia, and autonomous interfering activity of one limb, what is known as an alien limb phenomena. If we take a case-based approach, you can see that this patient has a stooped posture, flexed and is leant over to try to help initiate movement by shifting the center of gravity forwards. You can see the right arm, which has assumed this position of a resting pill-rolling tremor, an expressionless face, and a slow shuffling gait. To describe the features, we will follow the usual examination practices of focusing on the findings of inspection, tone, power, reflexes, sensation, and gait. On inspection, we noted the tremor which affects the hands, the index finger and the thumb, commonly calling the pill-rolling appearance. It's asymmetrical usually, where one limb has more symptoms than the other. Hypomimia, the lack of facial expression, a lack of blinking, the abnormal stoop posture, reduced spontaneous movements and hand gestures, hyperphonia, which is a soft, indistinct speech, are things that you would see on inspection. If you were to tap over the forehead, which is known as the glabellar tap, you would notice Meyersson signs, which means that the patient would continue to blink, although in normal physiology, if you continue to tap, after a short time, the patient will stop blinking. The tone in Parkinson's disease is increased. And in particular, the tone is rigid, which means that it's velocity independent. The hypertonia is the same despite the velocity of movement, and the hypertonia is uniform throughout movement, with the cogwheel rigidity as a result of the tremor. Synkinesis is where an activation maneuver can accentuate rigidity associated with Parkinson's. So if you ask the patient while examining a limb to tap the thigh with their opposite hand, the tone will increase. Coordination. You can ask the patient to make a hand grip repetitively, and what you will notice is their level of hand grip will slow down as they progress, and the width of movement will decrease. To examine coordination, you can additionally ask them to tap their toes against the feet as fast as they can. And again, you'd find a reduction in speed, a progressive reduction in amplitude and asymmetry, as well as a slowness in the initiation of movement. The gait also exhibits classical features, a slow initiation due to the failure of gait initiation with hesitancy, and the patient may stoop forward. The step length demonstrates reduced stride lengths, and short steps are common. Each step may get progressively shorter as the patient attempts to retain balance, and this is known as a festinating gait. The arm swing would be reduced on both sides, and the posture may be flexed or stooped. A patient may also have a tremor while walking. When the patient tries to turn, that would be slow and in multiple steps. So once you've picked up all of these findings on examination, to help determine whether there's a Parkinson plus component, you can assess the patient's autonomic function by determining their lying and standing blood pressure, and if there's a drop, consider multiple system atrophy as a diagnosis. You can assess vertical eye movements, and if there's a vertical gaze palsy or slow saccadic movements, this is associated with progressive supranuclear palsy. You can perform a cognitive assessment using a mini mental state examination, and if this demonstrates impaired cognition, you can consider dementia with Lewy bodies as a diagnosis. You may also want to ask the patient to write and draw a sentence or draw a spiral. And what you'll notice is a normal patient can copy the spiral, whereas a Parkinson's patient will draw a small micrographia, a small spiral, and you can see the wavy lines there as a result of the tremor. If you ask the patient to undo their top button, they'll have difficulty due to the dexterous nature of this task, and it will take them a long time. The key investigations: neuroimaging. Patients require an MRI brain, particularly of the nigrostriatal pathway, to assess dopamine levels, and you're looking for degeneration in the nigrostriatal pathway. To manage Parkinson's is a multidisciplinary team, patient-centered approach requiring the general practitioner, neurologist, the Parkinson's nurse, the occupational therapist and physiotherapist, as well as a pharmacist to ensure patients have a regular supply of medication with good compliance, and a speech and language therapist. Medications are there to try to increase dopamine. Levodopa in combination with a dopa decarboxylase inhibitor such as Sinemet can be used as first line, although this is contraindicated in melanoma. Other dopamine agonists such as ropinirole, rotigotine or pramipexole can be used, and conventionally previously ergot-derived dopamine agonists such as bromocriptine, pergolide and cabergoline were used. However, these were associated with severe cardiac valvulopathy and serosal fibrosis, and so are not favoured anymore. If the patient has a propensity to have freezing crises, apomorphine can be used subcutaneously as a dopamine agonist to try and prevent these crises. Other drugs include monoamine oxidase B inhibitors such as selegiline and rosegiline, and these are alternatives to dopamine agonists. These prevent the breakdown of dopamine in the synaptic clefts. COMT inhibitors such as entacapone and tolcapone are also useful, but have severe hepatic complications. If a tremor is a major issue for the patient, anticholinergics such as benzohexol can be used, but these will result in classic anticholinergic side effects such as a dry mouth, mydriasis and urine retention. So in this lecture, we've covered the case presentation of Parkinson's disease, the common questions, how to diagnose, the differentials, the Parkinson plus syndromes, how to investigate and holistically manage patients with Parkinson's disease. Thank you for attending this medicine masterclass.